All right, let's start back up. What I'm going to spend the next 2 hours is on the diseases of the valves. So we'll spend the first 30 slides on the first hour and the last 30 slides on the last bit. The monitoring and congenital heart disease will be talked about next week. Okay? So diseases of the valves is what we're going to cover now. Okay? Basically, we're going to go over, just very briefly, normal valve function. Then we'll go into the different forms of valvular diseases. We'll go into what happens when your patients develop stenosis versus regurgitation. Then we'll briefly overview some of the ventricular changes that you see. Then we'll go into a discussion mostly of left-sided valvular defects. So we're going to go into aortic stenosis, aortic insufficiency, mitral regurg, and mitral stenosis. Part of your homework over this week will be going over on your own about what the right ventricle does and right-sided valve problems. Basically, they mimic this, but they're slightly different in the sense they look at CVP and PA changes. So we'll sort of go through this first, and then if you have any questions next week after you've done some of the work on your own, then we can discuss it next week. All right, so normal heart function can be, when you're looking at normal valve function, you've got to make sure you separate the valves into two major components. One is the atrioventricular valves, which is the mitral and tricuspid valve, which separate the atrium from the ventricle. And these are pretty important valves in the sense that they allow for the volume to enter into the ventricles. The ventricles themselves are much thicker than the atriums, specifically the left ventricle being much more so than the right under normal conditions. The valve area is actually fairly large for the atrioventricular valves. So tricuspid and mitral valves are actually much larger, almost twice as large as the aortic and pulmonic valves. This is due because most of the actual flow is passive. 80% of flow that enters into the ventricles is mostly due to passive opening of the valve, and the other 20% is actually from active contraction of the atrium pushing the last bit of blood into the ventricles. The ventricular valves, on the other hand, are different. The ones that we're looking at, pulmonic or aortic valves, they're different in the sense that every single volume that has to leave has to do against a gradient. So it's pressure driven. Okay, so the ventricles themselves have to do the lifting work to actually enable the volume to be transferred out of the ventricles into the actual conducting arteries, which is the pulmonary artery or the aorta. The importance of that is that the valves are smaller, okay, because they're generating a greater force potential. And the other reason that you want to have smaller valves is that they can close more competently. So they're actually easier to close much more rapidly. There's no stenting on any of the aortic and pulmonic valves, in the sense that there's no struts like the mitral and the tricuspid valve, which have a papillary muscle network and the actual chordae tendineae that attach to the actual valve. So make sure you remember that the mitral valve only has 2 cusps, whereas the tricuspid has 3, which just kind of goes with tri. The normal valvular function, normal valve is 3 for both the pulmonic and the aortic under normal circumstances. Again, we're going to go into the cardiac cycle quite a bit. Reason being is because part of your examination, when you take your certification exam, is going to cover the valvular problems, and you should be able to identify, just by looking at the pressure volume loop, what kind of valvular problem you have. So I'm going to go into a lot of detail into this. Sometimes some of the books don't necessarily always coincide with some of my slides, and I'll explain to you why that is as we go along. But these are accurate, so make sure you sort of understand. The pressure volume cycle is not going to go away. I'm going to keep talking about it, especially when we talk more about medications and how they affect the actual performance of the heart. Make sure you understand that you got 4 different. When you're looking at this is the pressure volume curve for the left ventricle. So as a consequence, you're really looking at everything that's occurring in the left. So you got mitral valve opening here, mitral valve closure. Okay, from this point on, you get isovolumetric contraction, where the valvules, all the valves are closed at that point. You have your left, the mitral valve and the aortic valve are closed during isovolumetric contraction. Then you have the aortic valve opening, which has to do with the degree of amount of afterload that's being affected that heart. And then it ejects out, and that's why the volume drops. and eventually you get aortic valve closure. This correlates with the pressure over time curve, which we're going to go into a little bit more detail to make sure that you are reminded of all this stuff works. Part of the homework that you'll be doing is part of your cardiac workbook anyways, so it's something to reiterate what you're going to go over hopefully this weekend or this week with your buddies. Now, what happens when the valve becomes diseased? The importance of it is that the valve can only do one or two things. It's either going to become tight or stenotic, or it's going to become regurgitant. Okay? The other possibility is usually associated with things like bacterial endocarditis, which is perforation of the actual individual valves. That's more rare in comparison to most valvular diseases that we're going to talk about today. Bacterial endocarditis comes on pretty quick and abrupt in onset, usually from IV drug abuse or some other exposure, such as an abscess tooth can also cause it. So it's something you don't see very often in clinical, but it is present. But we're going to talk about more of the common, which are the ones like aortic stenosis and aortic regurg. Now, when the valve, let's say, becomes stenotic, what you see is that it increases the load on the chamber that's behind it. So if you're talking about aortic stenosis, that's the left ventricle. If you're talking about the mitral stenosis, then it's in the left atrium where you see this increase in load and increase in resistance. So it really depends on the valve. What happens as a consequence is initially the muscle will try to hypertrophy. The ventricles have a much more ability to hypertrophy in comparison to the atriums. The atriums just don't have enough myocardial mass to really hypertrophy significantly. So if you see the differences between ventricles in the sense that when you're going to get dilation, the answer is you see dilation late with the ventricles, and you see dilation much earlier in the atrium. So things like patients with a mitral stenosis, you tend to see very large atriums in comparison to somebody like aortic stenosis, where you see much more hypertrophy in that situation. Yeah, and the regurgitant valve, on the other hand, like aortic insufficiency and mitral regurg, it's a volume problem. And it's either too much or too little, depending on which chamber you're talking about. Ultimately, the most important thing is to have adequate preload inside the left ventricle, because that's what determines systemic circulation. So if you don't have enough, you're going to have limited effective ejection fraction. And we're going to talk about effective EF here in a minute to make sure that you understand the difference between effective and actual true stroke volume. People with aortic insufficiency appear to have a very large stroke volume, but actually it's very limited in their effective stroke volume, which is what's important. Unfortunately, with volume problems, you get usually a resultant dilation that's very prompt. And those things are not something that's easily reversible. In actuality, most things are like this are not reversible when we're talking about the heart. So that's a bad thing. So most regurgitant valve diseases you hear that are significant are the ones that you hear murmurs in diastole. Okay? Diastolic murmurs are much more serious because that's consistent with aortic insufficiency, and those are the ones that you have to worry about the most. Now, let's look at stenotic valves and what happens with cardiac alterations. Okay? If you develop stenosis and you're looking at the ventricle, the first thing that you'll get is what's called remodeling. Okay? The ventricle will remodel by hypertrophy. Okay? The hypertrophy moves the actual compliance curve up. So instead of seeing the normal inpatient position, which is, let's say this is the normal preload curve here, okay, the actual curve will shift upwards. Okay? It'll actually go up. Okay? That indicates to you that you have a decrease in ventricular compliance. So the ventricle is actually becoming thicker and becoming less compliant. Now, why does that matter to you? Well, it matters in several ways. One is it affects your PA occlusion pressure. It actually will give you higher PA occlusion pressure than you should expect for the same amount of volume. The other thing that happens is that the ventricle now is unwilling to accept volume as easily. Okay? So it takes more effort for the volume to enter into the left ventricle, which means it becomes much more dependent on the atrial kick to actually pushing the last bit of volume into the ventricle. So patients with this kind of remodeling do not tolerate arrhythmias such as atrial fibrillation or atrial flutter. And they actually can decompensate very rapidly on you and go into failure. If the hypertrophy occurs enough over time, and that usually requires several years, not acutely. We're talking about hypertrophy. Usually it's if you're looking at aortic stenosis, it's a gradual process that takes over 15 to 20 years to really build up. As it builds up slowly, the hypertrophy continues to take place. And this continues pretty constantly for all of 20 years. And then some people will actually present with failure with dilation. That's end stage. That's the terminal event. That's a disease process that now has gone to the point where people did not pick up on the hypertrophy, and now the heart is now remodeled into a dilated state, which is even if you repair the valve, guess what? The ventricle is not going to remodel. It's not going to go back down to a normal size, which is bad. Doesn't mean that we don't do valves for those patients. We will at times, but the morbidity and mortality is very high, much higher than a patient that's hypertrophied. If you, on the other hand, look at atrial remodeling, hypertrophy moves kind of rapidly, so rapidly that you almost immediately go into dilation. Okay, so atrial hypertrophy only occurs for a very short period of time and then immediately goes to dilation. So a patient like who has mitral stenosis, who usually takes up to 20 years to present, the first maybe 2 years of that disease process, you might see some degree of hypertrophy of the atrium. After that, the atrium now goes into a dilated state. So it does it quickly. The good thing is you do replace the mitral valve, even though it's a dilated state like that, the patient can still be okay. Okay? They can still tolerate it. It's a ventricle that does not allow that kind of problem to actually take place, and it's kind of not reversible, or it's very significant clinically. If you look at regurgitation is movement of large amounts of volume back into a chamber. If you look at both ventricular and atrial remodeling that takes place, they immediately move to dilation. They don't really go to hypertrophy very much at all. So if you have AI, aortic insufficiency, all these patients who are going to present with basically dilated hearts. Okay? If you have somebody with mitral regurg, that's either acute or chronic. In the acute stage, it's going to develop into pulmonary edema. If it's in the chronic stage, where it's more gradual, then it's going to dilate the atrium more quickly. Okay? Now, when you develop a dilation, what happens with your preload curve, this is your pressure volume curve, the preload curve actually shifts downwards. So it goes this way, which means that the ventricle is beginning to act more like the right ventricle and is able to accept a larger amount of volume and still not have a high PA pressures. If you see somebody with a really large heart, it's almost very kind of surprising when you're taking care of them that their PA pressures appear very, very low. Okay? And it's simply because this compliance curve has shifted downwards. And you can actually be fooled into thinking that everything is okay because the PA pressures appear to be like 10, and you think that the guy's a little dry, you keep pumping up with fluid. What happens with them is that as they go up on the volume, they pretty much stay flat, but then there's all of a sudden a rapid inflection point right here. And that inflection point puts them into the point of failure very rapidly. All of a sudden the PA pressures go from 5, as you get 500 cc's of volume, it goes to 6, not a big deal. Next one, you give another 500, it goes from 6 to 8, not seeming the problem. You give another 500, it goes to 8 to 22. Okay, that means you hit the inflection point, and that person now is in usually acute pulmonary edema. So this is kind of, the reason I'm teaching you this is to make sure that you understand this when you get to clinical. A number is just a number. You got to look at the whole picture. Okay, that's why people say PA catheters are not useful. They are very useful if you understand the model where you're at. What is it that I'm actually taking care of? If you do understand that, then the actual PA values are actually very useful. Now, what happens with different alterations in loading conditions? If you look at left ventricle pressure overload, this is from increased resistance. The major ones that we'll talk about is aortic stenosis today. The other one, which is really not a valvular function, but I sort of put it together because when you take your test on your certification exams, they include it in part of it. So I think it's partly should talked about in the valvular disease. It's really not considered a valvular problem because it's not a valvular disease, but it's actually a disease of the septal wall, which I'll show you a picture of that in a minute. But it basically acts like AS at certain situations. If you look at the other ones that we'll talk about today, which is left ventricular volume overload, the bigger one is AIs. okay, which is aortic insufficiency, which leads to left ventricular volume increases, annular dilation, and eventually leads to very significant MR. So a lot of times people with acute AI will present also with acute MR, which is bad, okay? And I'll show you a picture of that in a little bit. If you look at MR by itself, mitral regurgitation, if it's chronic, will cause a very dilated left atrium. So when the actual mitral valve opens in between cardiac cycles, it actually floods the ventricle again. So you can see dilation with MR as well. Usually MR, though, leads to a low preload state in a lot of situations, or basically an inadequate stroke volume, because the effective stroke volume is actually being regurgitated back into the pulmonary circulation. The left ventricle pressure and volume overload conditions are things like mitral stenosis. That should be really a right ventricular pressure and volume overload condition. Mitral stenosis is really a lack of volume inside the left ventricle, as well as a drop in pressure in the right ventricle. So please correct that on your notes. It should be RV. Should be right pressure and volume overload. Okay, because it leads to inability for the volume to empty out of the atrium into the actual ventricle. So the ventricle is essentially dry. So let's look at the actual compensatory mechanisms first. Let's look at what happens with pressure overload conditions. We show you here. This is a normal, well, they don't show a normal heart here. This is a heart that has become thickened initially, so this is the actual pressure overload, such as a patient that has aortic stenosis. And in this case, both ventricles are actually become hypertrophied, so this could be a pulmonary hypertension patient or something like that, so the actual ventricles are both enlarged. And then you see it go into a dilated state, is eventual end-stage result of it. Okay? The other thing that happens with long-term effects of valvular dysfunction is that as your effective stroke volume begins to decrease, the actual sympathetic nervous system inappropriately becomes activated, in the sense that it perceives decreased perfusion. The downside to it is that it begins to increase afterload as a result of that. So increased sympathetic tone normally will increase the afterload and actually makes things like aortic stenosis even worse, okay? Because it increases the afterload effects on the valvular opening. So sometimes treatment is to actually drop afterload in some of the disease states, and you've got to be careful on how to manage that, so we'll go into that in a little bit more detail. We will all go into this as well in coexisting and give you more clinical examples on how to manage some of these things. The other thing that you see is that you see alterations in the atrionatriuretic factor or atrionatriuretic peptide. With some of these dilated states, ANF actually drops off and does no longer activate, versus in the acute stages, ANF can be an important factor to diurese the patient, but in long term, unfortunately, once you get atrial dilation taking place, ANF shuts down. You also get this altered ventricular compliance that I've sort of implied to you before. You see a diastolic dysfunction because of that, where you have, it's just for hypertrophy. You have impaired capacity of the left ventricle to fill and to maintain its stroke volume without a compensatory increase of atrial filling pressures. And usually it's also due to impaired ATP production, because remember, as the ventricle becomes thickened, what happens to perfusion? It becomes limited. And so sometimes this hypertrophy is a bad thing in the sense that it increases the risk of oxygen utilization, and it increases the risk of developing ischemia in these people. Eventually, this altered ventricular compliance leads to these changes that we consider LVH. This is a typical patient with aortic stenosis. This is the degree of hypertrophy that you're looking at, okay? And you can see one of the muscles that's really pretty impressive is the papillary muscles. The papillary muscles have greatly enlarged. And you've got to ask yourself why. What do? What's their job? Do they really contract? Right. They hold the mitral valves closed. So they actually have to hypertrophy to hold the valves to stay closed. So if you think about it, the epicardium is where the actual coronary arteries are at, and they actually send in perforating arteries all the way down to get it to the actual oxygen to the papillary muscles. So if you develop ischemia in this area, the first thing you're going to see is incompetence of the mitral valve. So you're going to get a lot of times with AS, as the disease progresses, you're going to get mitral regurgitation. And almost everybody that has significant AS where we can actually do the surgical repair, when you do the TEEs on them, almost all of them have 2+ MR, if not more. Okay? It's usually pretty impressive. Once you fix the problem, you replace the valve, the MR goes completely away. So you don't have to necessarily replace the mitral valve. Okay? Sometimes it's just from the high pressures that are being generated inside the ventricle that's causing the problem with the valve dysfunction. Again, of course, when you develop this issue with myocardial ischemia, what you have to look at is that your ventricular compliance is actually decreasing. So you're getting, your preload curve is doing this, and it's moving up. Well, that is your left ventricular end diastolic pressure is going up. Okay? Which means this number is actually increasing, while this number may actually be falling. Because ADP is dependent on what? Vascular resistance and stroke volume. Right. And the stroke volume is actually diminishing in patients with aortic stenosis. So your ADP is going to fall. So that's a double whammy. You're increasing the intraventricular pressures and you're decreasing your ADP. Both are increasing your risk of developing cerebral perfusion pressure issues. And that's why you don't want to do a spinal on anybody with severe aortic stenosis. Now, things that you also see is that with ventricular hypertrophy, you see an increase in workload. This is from the increases in afterload, increases in contractility, and also the changes in heart rate that you see in these disease states. A lot of times when you have fixed stroke volume, what happens to heart rate? It begins to increase. That's the only way you can compensate. The downside to that is, look at this. You have to move that more than 40 times a minute or 50 times a minute. If you're going 100 times a minute, that's really working the person a lot harder. The other thing that usually leads to death in these patients is cardiac dysrhythmias. If you have a atrial fibrillation or atrial flutter that develops, that can actually be lethal to these individuals. Most of the time, atrial fib, atrial flutter, and people that are normal, they don't even notice it. But these people very much notice it, and they drop their cardiac output, and now they have really a drop in perfusion pressure, and then they get ischemic, and then they usually get into a malignant arrhythmia like VTAC or VFib. Okay, not good. And once these people arrest, they usually don't come back most of the time. Sometimes you also get a bundle branch block secondary to dilation. There's a late effect as well because it progresses into the dilated state eventually. You also get myocardial dysfunction, failure, and eventually sometimes you also develop MR significantly to develop pulmonary hypertension in these individuals. So let's look at the individual pressure overload conditions. Let's start with aortic stenosis first. Aortic stenosis and IHSS is the other one, which is a subvalvular disease, which I'll show you in a minute. Okay? Now, the normal aortic stenosis that you're looking at is the most common LV alpha obstruction is from aortic stenosis. Most of the time it has to do with either the patient has rheumatic fever as a child or has been born, unfortunately, with a congenital bicuspid valve. Why is that bad? Well, here's an example. This is what a normal tricuspid valve opening looks like. You can see that the valve area is almost the same as the diameter of the actual aorta. Pretty impressive, okay? But this is what a bicuspid valve does only, okay? So that's limited, so what does that mean? If you make an orifice smaller, what happens to flow velocity? It increases, okay? And when you increase flow velocity, you tend to shear things more. You tend to damage things. And that's what ends up happening. With bicuspid valve, the actual valve itself becomes damaged, and what you will see is that you will start depositing calcium. Okay? Calcium will then accumulate from the outer edges and move inwards. It never moves from the center outwards. Okay? So the actual valve will become smaller and smaller in this area. Eventually, some of the cusp, if this is a tricuspid valve, you can see how one of the cusps is completely fused, and it looks like a bicuspid valve. When you take these out and look at it, when you flip it over and look at the other side, you can actually see that it at one time was a tricuspid valve. It looks bicuspid when you're looking at a TEE, but it's really is because it's a tricuspid valve that's completely fused. The lowest area that I've ever seen was 0.4 centimeters squared, which is really, really small. The normal area is about 2 centimeters squared, which is the size of your thumb. So that's pretty symptomatic. At 70% reduction, which is around 0.8 centimeters squared, you have symptoms of severity. Okay? And to be down at 0.4 is almost lethal. If you make any mistake in your induction, game can be over pretty quick. Okay? So it's one of the things that you got to sort of be aware of when they tell you what kind of valve area that you have. The other thing that we'll talk about a little bit is we'll also talk about gradient. And I'll show you what gradient means in a minute. Yes, sir. Ma'am. 2 to 0.8. That becomes very significant. Okay. There's also, if you work here in Naples, it's just a normal valve wear. After a while, the valves will wear down. Okay, so it's called degenerative. It's the most common. It has to do with calcium deposits and restricted movement. Rheumatic fever, of course, is an infection that aggravates the situation. It's almost like a vasculitis that you get. And it attacks the valves. And, but the degenerative in our population is the most common, and by far that's what happens as you get older. If you look at the normal valve area, it's about 2 centimeters. This is where the symptoms occur within you're down to 0.8 centimeters squared. Okay? It leads to chronic obstruction of left ventricular ejection, and it leads to an increase in intraventricular pressures. This leads to the ventricular hypertrophy with increased muscle mass, stiff or less compliant ventricle, in the sense of the left ventricle. It requires more pressure to inflate or fill the ventricle, and requires the atrial kick to be important. Up to 40% of the left ventricular end diastolic volume is due to atrial kick, instead of normally 20. So that becomes pretty important. There's also increased risk for ischemia, increased muscle mass from that, increased workload, increased LVDP. All those lead to an increased risk. What the clinical findings are is that the patient's going to be dyspneic on exertion. The reason being is that the valve is causing obstruction and not allowing adequate flow coming from the right ventricle to the left. So you start getting a little bit of a decreased lung compliance because more water begins to accumulate in the lungs. So these people become dyspneic on exertion. The other part is that to get dyspneic is because the amount of workload that they have is pretty high. And if they start trying to move a little faster than they normally do, their cardiac work output increases dramatically, and they can actually start getting angina. That's usually a pretty bad sign. And the worst one, of course, is they develop syncope. Okay? If the person is developing dyspnea on exertion, they think they have like a 5-year survival rate is about 50%. If they develop angina, it's a 2-year survival rate of 50%. And then once they get a syncope, they're dead 50% of the time in a year. So it's 50, 50, 50, you will. Okay? 5, 2, and 1 year. Okay? So it's pretty bad. So if the person is developing syncope, that's a very high severity grade, and that means that you're not perfusing. A lot of times after that is you get sudden death, okay, which is one of the few diseases that can actually cause sudden death. Aortic stenosis is one of those. Okay? You can see here in this picture, this is a bicuspid valve, a true bicuspid valve that is fairly significantly fused. Okay? And you can see, of course, this is not a good sign because it's a pathological specimen. Okay? And what you're seeing is very limited flow. When you look at it on a TE, you can actually see the valve not opening at all, and you can actually just see squirting a little bit of blood. And it's actually pretty amazing that you can see people actually walking around with some of these valves that are so tight. What you hear on heart sounds, and some of you got to be very good at picking up, is what's called a crescendo-decrescendo murmur. Okay? Before you do any regional anesthetic on anybody, which means a spinal or an epidural on anybody, you must listen to the heart. Okay? If you don't listen to the heart, you will miss it, and you may kill somebody. Okay? This is one of the few diseases where if you miss that somebody has significant aortic stenosis and you put a spinal in, game will be over very quickly. Okay? You can do them. I've seen people do it, but I would not recommend it, especially if you didn't listen to the heart. It doesn't make any sense to do that. What you hear is a crescendo-decrescendo murmur between S1 and S2. So it's a systolic murmur. Okay? And usually it will radiate from the aortic here, goes to the neck. So you go crescendo, decrescendo murmur. Really easy to hear. Once you've picked it up once or twice, you'll never forget the sound. So what usually I do is when I'm working in clinical, if I hear somebody with AS, I make sure that you all come around and take a listen to. There's nothing like a patient can teach you than a simulator does. So. Now what you'll see is that this is a normal pressure over volume curve and how it correlates with your pressure over time curve. This is more, again, this is a review. And I'll show you what happens with your actual aortic stenosis. What you see in this red line here, this is the contractility line. This has to do with the slope of attack. This has to do with this contractility line as well. If you look at the actual mitral valve opening, that's down here. Aortic valve opening would be here, where the ventricular pressures meet with your aortic pressures. That's when the valve actually opens. Okay? And then you can see here with the aortic valve, which is a diachrotic notch right there at that point of the cusp of that diachrotic notch, that would be your aortic valve closure point. And then your mitral valve opening is down here. Notice that your largest V wave is right here, which is the greatest amount of filling of the left atrium right before the actual mitral valve opens. And you can see how rapidly it empties. Okay? And the pressure drops off very quickly. Now this slope is going to be important in the sense of what happens when you're looking at aortic stenosis. So let's look at what happens with aortic stenosis in the sense of your pressure volume curve. This is a normal individual here in the black. Okay? So this is a person with a normal preload curve. What happens with aortic stenosis is that you'll see a shift upwards of their compliance to decreased ventricular compliance. So now their preload curve went from the green line to the red line. So for the same amount of volume, this individual is going to require a higher PA pressures. And when you take care of patients with aortic stenosis, you'll notice that your PA pressures have to be around 20 to 25. Even when you come off bypass and this person has the aortic valve replaced, you're still left with a what? A stiff left ventricle. The ventricle hasn't changed because the valve has just been replaced. Will the ventricle change eventually? Yes, but it'll take about a year to 2 years before it actually goes back to a more normal state. And it'll never go back to absolutely normal. Okay? That being said, that means those people will usually require more pressure to keep the same volume in them. So a lot of times, you're thinking about, well, the PA pressure should be 15. No, in this individual it should be higher. It should be like 20 to 25, and that's okay for them. They're actually happy there. If you try to drive them down to 15, they're empty. They're down here. Okay, so they're half the volume they should be. And they become very, very symptomatic. And usually people tell you clinically, these people need more volume. That's what they're talking about. They need more volume in their ventricle for it to be effective, in the sense that their preload point is actually up here. Okay? And you can see in the black line and the dashed line what happens with aortic stenosis is that you go from a afterload pressure here to a new afterload pressure up here. And if it's uncompensated, you get the first blue line, which is up here. This is the contractility line. So this shows you, just for aortic stenosis, if you're not compensated, which means you're not increasing your contractility, that individual has a decreased effective stroke volume. Okay? The actual stroke volume has been reduced just because of the increase in afterload. Now, the way the patient will compensate for it is that they will shift out to the new ventricle hypertrophy will make it have a better contractility. So the effective stroke volume will be slightly reduced as a person that gets sicker, but it's still doing okay, because of the hypertrophy. So the hypertrophy gives you that benefit of improving contractility. Does that make sense? Now watch what happens when you do the next part, which is what happens when you correlate it with a pressure over time curve. How does it change your A-line waveform? And the answer is that this contractility line, which is in blue here, is shifted this way. So it's going to make the arterial line as well as ventricular compression become more vertical. So the new ventricular pressure is going to be shifted and give you a much more rapid ascent, which means that when you see the valve opens and closes, it's shorter in duration. So in aortic stenosis, your aortic pressures, when you put your A-line in, look narrower than they should be. Okay? So you'll see a rapid upstroke with rapid descent. And actually, that can lead to problems eventually, in the sense that if you don't have enough ejection, this will narrow down quite a bit, and then you will start seeing drops in diastolic pressure. Now, if you look at the actual ventricular curve, when you actually put if you put a catheter inside the left ventricle, like the cardiologists do, what they'll actually measure is the intraventricular pressures, which is in the blue line. The blue line is what is actually measured inside the ventricle, and the red line is what you measure in the aorta or the radial A line. And you see that there's a difference. Normally, there's no difference. Normally the PA pressure, so the aortic pressures and the ventricular pressure should be the same. But in this disease, because the valve is stuck, not being able to open fully, you develop what's called a gradient. That's the difference between the intraventricular pressure versus the aortic pressure. The greater the gradient, the more severe the disease process is. Okay? Now, aortic stenosis is a valvular problem where you cannot change the afterload. The afterload is fixed in these individuals. Okay? You can't change it. Because you can drop the blood pressure peripherally, yes. So will that decrease the afterload? Yes. But does it really affect the afterload that the ventricle is seeing? And the answer is no. Okay? So when you do a spinal, under normal conditions, the afterload drops. And then what happens to stroke volume? It dramatically increases normally. Okay? Let me just go back one slide. That was dumb. I always hit the wrong point. Okay. Okay. If I were to take a normal individual and I dropped their afterload and did it from here down to here, then what you should see is that there should be a more effective stroke volume. Okay? With aortic stenosis, when you do a spinal on them, guess what? That doesn't happen. All that happens is that your diastolic pressure falls very quickly. Okay? But your amount of stroke volume is unchanged. Now, what will happen is that when you drop the diastolic pressure that fast, what will happen to coronary perfusion pressure? It drops like a rock. And the person develops ischemia, and then the ventricle can't pump. And it becomes stiffer. And then the game's over. Okay? That's why you don't do spinals and epidurals on patients with aortic stenosis, unless you're super, super careful. And I would not recommend it, put it that way. So here's what you see with aortic stenosis. This is a normal individual over here. You can see how the ventricular waves are completely the same as the actual aortic waveform, in the sense that they're overlying each other. But you can see in the aortic stenosis curve, you see this curve that shows you the amount of gradient that you have here, which is intraventricular pressure. The other thing that you'll notice is that your PA occlusion pressure is increasing, which is what they're showing you here. They're showing you that the actual PA occlusion pressure is rising as a consequence of the disease process because of the decrease in the actual ventricular compliance. Okay? Now, I see some people who don't seem to be very interested. So let me just tell you one thing. Okay? If you're not interested, that's fine because you think it's too technical. But unfortunately, this is our job. Okay? So if you're not into mathematics and not looking at actual pictures like this, if you can't glean this information, you're going to be a half clinician. You're going to be good, but you're not going to know really what's going on. If you have an understanding of this, it's not so much for passing your certification exam, it's to make you a good clinician. And a lot of times these books are very confusing on how they're trying to teach you. So if you're not trying to pay attention now, make sure you pay attention to listening to the Camtasia later on. If you guys are tired for the exams, I understand. But make sure you sort of pay attention to these curves and try to make sense of them and talk to your group about it. Because really, if you understand this stuff, you'll really be better clinicians. And that's what I'm trying to teach you here about. Okay? So, if you look at AS with MR, this is how it can be useful. This is a patient, let's say, if you look on the left-hand side, to your left, this person has aortic stenosis, and they went from, in the blue, to being compensated, okay, where they get nice ventricular hypertrophy. And now, with time, this person is developing some degree of ischemia. Their ventricle is now dropping its compliance curve, so it's shifted. And now the new red box is a patient with severe aortic stenosis, and now they're already showing signs of low stroke volume. That's bad enough. But now let's add one more problem. Let's now add the person to have MR. All of a sudden, the ventricle goes into a dilated state very quickly. As it begins to dilate, the valve becomes incompetent. Okay? So you already have a very high elevated preload curve. And now you get MR, which I'll show you here in a little bit. And now what happens to your effective stroke volume? It disappears. Okay? And these people will rest on you very quickly. So when you go from AS to MR that's acute, the person goes in acute pulmonary edema and tries to die on you, right on the spot. And these are the patients that usually were brought into the last minute brought into the operating room, and they have frothy edema come out of that, and tracheal tube. This is the people that have this kind of problem. But that's how it's described when you're looking at the actual pressure volume curve. And we'll make a little bit more sense when we show about MR. But so the reason I'm sort of showing this is that you can take two valvular problems and put them together to generate a pressure volume curve. And then you can sort of make your clinical determination, what happens if I do one thing or another. And you can actually play with this before you get to clinical and sort of make a determination what will work and what won't. And this is what I actually do in clinical as well. I actually will sit there and draw sometimes of this stuff and then see what happens when I give a medication. If it's not doing what it's supposed to do, I don't blame it on the equipment. I blame it on myself, that I don't understand what's going on. And then I reapproach it and try to figure out what the problem is. Because eventually, once you know what the problem is, it will follow what you're doing. It does start doing what it's supposed to do, which is the expected things that you see with the medications. Let's go into IHSS next, and then we'll stop after this and start. Yes. Right. Right. And this is where you're starting to dilate, okay? And then you add the mitral regurg to it, which is we'll talk about in a little bit. Okay? And this is severe mitral regurg. This is very, very bad severe mitral regurg. Okay? Okay? And this is bad news for this guy. This guy usually start dying on you. Let's go into IHSS next, which is idiopathic hypertrophic subaortic stenosis, also known as hypertrophic cardiomyopathy. Most people now call it just IHSS. It's a congenital problem, which is the number one cause of sudden death in people under the age of 30. It's becoming recently good, important press because you have the Olympics coming up, and unfortunately, because of the remodeling that occurs from these athletes, some of them will have this problem. Hopefully none of them, they've had echoes, so they don't have this problem, but you just never know. It occurs at all ages, so you can't really, say that if somebody's in their 40s, it's going to be fine. No, but most of the time it usually presents early in life because that's when people are exercising their maximal level. And what you see in these individuals is this nice pressure waveform. The reason I've got this picture in here for you, this is a person that has IHSS. It looks like a person with aortic stenosis, where you see the ventricular pressure waveforms different than the aortic pressures. But one of the things that's really very, very pathognomonic of this disease process is when the person goes into PVCs, look what happens to the actual ejection volume that empties. This person is extremely preload dependent, and as soon as you get into a PVC state where you don't really allow atrium to actually empty into the ventricle adequately, you see very rapid drops in blood pressure, and then eventually swings back, and this person will stabilize. But hypertrophic cardiomyopathy basically is asymmetric hypertrophy of the intraventricular septum. So instead of being the whole ventricle modeling, it actually only remodels in the septal wall. The reason that's important is because the septum becomes increasingly bigger and bigger and bigger, and eventually forms an outflow obstruction right here, where it begins to almost meet and touch the mitral valve cusp. If that eventually does touch, then the ventricle can't empty and the person will rest on you. Okay? So what your job is to prevent, and I've taken care of quite a bit of number of people with IHSS here, is that you got to prevent them from getting into the situation where they can get into trouble. Okay? And normally, they actually will present with no real big deal. Okay? Most of them are actually don't have any symptoms. What eventually will happen is that you get some degree of diastolic dysfunction, usually not significant enough to be problematic unless you're exercising severely and sweating a lot. Okay? And eventually leads to a complete left ventricular opposite tract obstruction and causing death. So that's what causes sudden death. And this is the kind of picture. This is a normal heart here going to a hypertrophied state. I want you to specifically pay attention to how much distance there is between the actual septal wall and the mitral valve. And you can see it's approximating it closer and closer as you get into this more progressive disease. Now, what makes IHSS worse is think of a Venturi effect. Venturi is like a little jet engine that you blow through. Okay? If you increase the velocity of the flow, the more rapidly the shutters come together. So, and that's what you're trying to avoid. So increasing contractility is a bad thing in this disease. The major culprit, which we'll go into a little bit in detail about what happens clinically, is the decrease in preload, which is what starts everything off. So decreasing volume is a pretty important prerequisite for developing sudden death from IHSS. And then also the rapid decrease in afterload and the increase in heart rate. All these will cause problems. So let's see how is it eventually doing that. Essentially, when you empty out the ventricle, it begins to eventually approximate the mitral valve to the septal wall, and then the outflow obstruction will take place, and the person will arrest. Now, who is at risk for arrest from IHSS? And it's usually are young people that are usually sweating and exercising heavily. So usually people that look perfectly healthy when you actually meet them. And if you're working in a family practice situation, these are the nightmares, in the sense that these are the kids that come in for a physical, and you listen to them very carefully, and you're doing all your best that you can do, and guess what you hear? Nothing. It sounds totally normal. These people are completely asymptomatic when they have adequate volume. So most kids that are coming into your office are not going to be sweating and be dehydrated. Okay, so that's usually ones that you'll never pick up. Instead, you'll find out later that the person has died at a major function, usually playing football or playing something, soccer. So what you're seeing in the situation is that these kids are in situations where they have an increase in heart rate. The reason the increase in heart rate is so important is that it drives your preload state, what? Up or down? It down. As you increase heart rate, you effectively remove more volume out of the ventricle. Okay, so your preload is actually dropping. And that's exercising. So when you exercise, your normally heart rate increases. Not a big deal, right? Well, when these kids, now they begin to run in usually very hot weather like in Florida. So they're sweating tremendously. So now they're becoming acutely dehydrated. So that means a drop in preload. And that still doesn't kill them. Okay? It's usually right when they're going after a ball, when they're going to do the last bit, they're going to do the maximal effect. So their sympathetics crank. Okay? And as their sympathetics are cranking, initially what happens is you get vasoconstriction. But the last second, as you develop the overheating, what happens to your sympathetic tone in your skin? It vasodilates. And that drops your afterload rapidly. And when that does that, the patient goes into emptying the ventricle more fully. Now the ventricle is now touching, and the game's over. The kids drop dead on the spot. So overheating is a really big issue in the sense of this disease process. So almost invariably, you never see these kids where they're not sweating. And they're usually in hot situations, very hot situations, and they're overheating, and that's when they arrest. You never see them arrest during the beginning of the game. It's usually always in the middle of the game where they're doing their most amount of force that they're trying to achieve. Yes? You don't want them to be tachycardic. That's what their initial clinical presentation is going to be. They're going to increase heart rate initially, drop their preload. Then they're going to decrease their sympathetic tone, which is going to cause their outflow to make it even worse, okay, because it collapses everything down. And then you're going to have the arrest on your hands. Okay? Yes? What's that? Say it one more time again. Yes, like a vapor lock. Right. Right. And once the ventricle is collapsed, it doesn't want to re-expand. There's no more reason to open up, and the pressure goes to zero. And CPR doesn't work. Right. There's a valve that stays closed. Can't open it. That's the next thing I'm going to talk about. Because now it's totally theoretical, because most of these kids that actually die in the field stay dead. Because nobody knows how to really treat these kids. Most of the time I've seen these things happen is usually on TV, like everybody else, is a kid just sort of drops. And then you see the coaches run, and then you see them start CPR, and they don't do anything else. They're just doing normal CPR. What they have to understand is this is not normal CPR. This is a low preload state CPR. Okay, this is a severe dehydrated state. The only thing that's going to turn over the heart is increasing afterload very quickly and increasing preload quickly. Okay? So I'll show you a maneuver of that, how to do that here in a minute. Okay? So this is a person that presents to you with IHSS. When you look at their pressure volume curves, they look absolutely normal. So these kids are fine. They don't hear no murmur, nothing. Okay? As the person becomes dehydrated, okay, where you lose intraventricular volume, then all of a sudden the preload drops very quickly. Now notice one thing. What happens to the afterload? It goes right through the roof. So it acts like an acute AS. Okay? And what happens with that rapid increase in actual afterload is that your stroke volume goes to almost a zero. And that's what makes these kids arrest. Okay? So things that will cause problems with low volume, which is decreased preload, increased heart rate, those are the major culprits of decreasing that preload point. That's what initiates everything. And then what actually finishes you off is that the contractility will increase. And when you do that, you actually empty the heart even more, and you'll slide it down even more, and decreased afterload will actually finish you off even more. Okay? It's the driving the pressure down that causes the acute increase in afterload inside the actual ventricle. The afterload decrease is talked about is peripherally. It's you're unloading, you're letting the ventricle empty even more, and that's what kills the patient usually when they finally develop this problem. So what you see in these individuals, if you look at this individual here, this curve is actually completely normal. So they actually, just like a normal patient, they have, when they have adequate preload states, their preload's okay, their aortic valve opening and closure looks okay, so their waveforms all look okay. But then when the person develops this all of a sudden rapid AS kind of symptomatology, they get big gradients that develop, and all of a sudden this person will rest on your hands. Yes? Nope. The increase in afterload is you have to think about it, it's like a valvular stenosis, but it's inside the septum, inside the ventricle itself. So the afterload is, when we're talking about afterload, is what the ventricle sees, not what's the afterload that's going out in the periphery. And that's really kind of important. If you think about it from the sense of periphery in these people, that puts them into the rest mode, is that they vasodilate. And when they vasodilate arterially, they decrease their afterload, sort of, but it empties the ventricle and then it collapses more the septal wall. And that tremendously jumps up the afterload inside the ventricle itself. Okay? Does that make sense or not really? Here's the ventricle, normal. Okay? This is the mitral valve here. And then you have the outflow tracts up here. That's normal situation. In this person, this septal wall is like this. Okay? That's a disease process. Okay? Now what happens is, as the ventricle begins to, the volume inside here becomes smaller and smaller, this becomes smaller here. Okay, and this becomes, actually reaches over and begins to touch the mitral valve. So what happens to the orifice here? Right. That's what's driving the afterload up for the left ventricle. Okay, but what actually kills the people is that you get vasodilation and the ventricle empties more effectively for 1 or 2 stroke volumes, and now it's touching and the game's over. Now the ventricle is empty and it's completely obstructed. It won't fill right back up. Nope. And usually by that point you have no diastolic pressure and you're basically in VTAC. Okay? So the question is, what do you do? And you can do surgical treatment, which is what we have done here in the past. What you do is you actually cut away the septal wall and you denude it, okay? And then it goes back to normal. It actually re-epithelializes in about 6 weeks and seems to do okay, so you have to put these people initially on anticoagulants. But after that, for about 6 months, they're taken off the anticoagulants and they seem to do okay. This is a pretty major operation, as you can imagine, and with significant complication rates, because what's right down underneath here? The bundle of branches. So you might get knocked out a left bundle, or you might do a complete bundle, and you get complete heart block. So a lot of the times these people might need a pacemaker as well. Okay? Now treatment is regular ACLS doesn't work. We do know that. We've watched it enough times on TV, and I've seen it enough times where somebody comes in like this. I had 2 kids come in into our ER, and they called us because it was a trauma alert. They didn't know what was the cause, and both these kids died, and that's what made me interested in doing this. So the only thing that we can envision, at least after discussion with not just myself, but actually I discussed with like about 5 or 10 different doctors and some people that are preeminent in the area in the sense of resuscitation. They said the only thing that would actually work on these kids is to give their preload back as fast as you can. Okay? So the best way to do that clinically would be to elevate their legs. Okay? So when you go to this code, if you ever had this happen, you have to elevate these kids' legs. Okay? Once you elevate the legs, you get 500 cc's of volume back from both legs. That's a pretty significant preload return. Okay? And then the next thing you do is you take the legs and crunch them. The reason you crunch them is to basically occlude the femoral arteries completely. And to do that, you increase the afterload, and that would hopefully drive the diastolic pressure up as CPR is given to hope to turn the heart over. But that's the only thing that's really going to continue to work. If that's, hopefully if you ever see that, you'll do that, you'll actually make a difference in that kid's life, and maybe you can bring him back. But everything else pretty much is pretty much useless. Epinephrine won't work either, in the sense that even if you give it early, it's just the valve is completely, the volume is completely empty. The epinephrine won't work against an empty ventricle, so you really need volume. And the other possibility, which is usually what we talk about in the OR, is like if this happened in the OR, what would you do? And my answer would be, I would actually enter into the chest and actually put it in a cannula in the left atrium and fill the heart that way with volume directly. Okay? But that's pretty aggressive. That's not something you're going to be able to do in the field. Okay? But it's something we talk about clinically in the sense that we would do that if you were in the OR. Yes. That's another thing that people have discussed. Does anybody know what abdominal thrust is? It's called counterpulsation therapy, which you're doing. One person's doing CPR and the other person's doing abdominal thrusting, which is you're pushing down. That increases venous return, and it also increases afterload, so that might be effective. The problem with it is it's too much higher incidence in rupturing an intestinal tract or a spleen or a liver. So there's been a lot of complications with it. At that point, you might not have anything to lose, but something to also to consider. I've done counterpulsations on people, and it seems to work sometimes and not others. So it's really hard to say which will work. At that point, try everything. But try the leg first and try to compress them. This is like a TET spell, which we'll talk about next week. You can sort of treat it like that. Okay? Only for about 30 seconds or so. Doesn't take much to, and then you just compress them after that. Maybe about 10 compressions, and then you move on. It's enough to empty the actual volume out of the legs. So, at least that's theoretical. That's what might actually work. So, all right, mitral stenosis, mitral regurgitation is the next discussion. Okay, mitral regurg is associated with a lot of other valvular diseases. AI, aortic stenosis but mitral valve regurg can also be just by itself, independent. You can get it acutely from a myocardial ischemia or infarct, especially if it involves the papillary muscles. The papillary muscles or the cord tendon, they can actually be torn or rupture, and usually they present with acute pulmonary edema from that presentation. And also the mitral valve, because it's such a large valve, has a more surface area to accept infected myocarditis, and chest trauma may also occur. Usually that's not the most frequent valve that gets damaged, because the mitral valve is posterior in the chest, the left ventricle is posterior in the chest, so it's less likely to be injured in comparison to the tricuspid valve. If you look at the chronic diseases where you get mitral regurg more in a slower indolent state, like rheumatic fever, congenital development can also be problems. You can get a cardiomyopathy where it dilates the heart and then leads to annular incompetence. And you can get destruction from infections or infarctions, and also you can get calcification in the mitral annulus, which eventually causes a tear to take place. One thing that's important about the mitral valve, when we're talking about regurg, we're not talking about the mitral valve prolapse, we're talking about actually true regurg. So it's actually due to an anatomical disease process of the valve. Remember, the anterior valve is the more prominent of the two valves. The posterior valve is actually fixed and doesn't really move that much, but is really the anterior valve. It's really the disease process is taking place. If you look at a normal individual, what should happen during systole is that the mitral valve should remain closed during the isovolumetric contraction phase until the aortic valve actually opens, and then the effective ejection goes out into the aorta, nothing going back into the left atrium during that systolic cycle. What you see with mitral regurg, on the other hand, is that the mitral valve becomes incompetent, and a certain percentage of the actual volume inside the left ventricle will eject back into the left atrium. The greater the percentage of volume that enters into the left atrium, the more prominent the symptoms will be in that patient. Okay? So in other words, the more incompetent the valve is, the more severe the disease process is. The other thing is also dependent on if it's chronic or acute. In the acute state, the atrium has not had any ability to dilate properly, so usually the PA pressures will be much higher as a consequence, which also left atrial pressures will be much higher, even though the volume is actually maybe a little bit less or the same. Versus a patient who has chronically dilated mitral regurgitation, they get a chronically dilated left atrium, which can accept this volume, and you may not see as much of an increase in your left atrial pressures. So what you see in mitral regurg is you get a significant reduction in the effective stroke volume due to loss into the atrium. You get large dilated atrium under chronic conditions, and you eventually develop a dilated cardiomyopathy. You do get elevated PA pressures in almost all the disease process, especially if it's significant. Okay? And then you'll see a very large prominent V wave on your PA occlusion pressure. And that's the typical pathognomonic sign that somebody has an MR when you're looking at a PA occlusion pressure. Acute, you see no dilation in the atrium, but it results in very much rapid increases in PA pressures, which results usually in rapidly in acute congestive heart failure, or what we call pulmonary edema. Okay? So what do you see in MR? Well, now, and this is where the confusion part. When students come back to me and ask me, well, why do I see it this way? Because MR is a disease process in the sense of severity. Okay? Some people have very mild MR. Some people have moderate MR. And some people have severe MR. Okay? And as a consequence, when you draw it on your pressure volume curve, it varies between the disease process that you're looking at. Where the actual disease is in the mitral valve. The mitral valve is down here. Okay? It's here where the mitral valve is opening or closing, in a sense closing right there. Okay? So the disease process that we call mitral regurgitation means that that valve is going to leak right at that point or somewhere in that line, in that pressure, in that volume line. And if you look at patients with acute MR that's mild, okay, what you'll see is the ventricle begins to contract. Okay? It normally should be reaching all the way to the black lines here, all the way to this new red point, to basically the mitral valve is remaining closed in the whole isovolumetric cycle. But you see down here, with this red arrow is at, right there, that's where the mitral valve actually becomes incompetent. So the mitral valve is actually holding for this individual to around a pressure of around 100. And around an intraventricular pressure of 100, the valve breaks open and starts leaking. Okay? And then it ejects a little bit of volume out into the atrium, but not a big portion of it. If you look at the actual effective stroke volume of this individual, it's still very effective. Everything from this point on is effective stroke volume. This point here is volume that's lost into the left atrium. So most of the time, mild MR, you're not going to have very much notice of anything. Patient's really going to become pretty normal unless you drive the intraventricular pressures up. When do you do that? When you exercise. Okay, so when you're running around. Okay, so if you also overdilate the ventricle, you will make this more prominent. Okay, so if you increase volume in somebody with MR, you will make them worse. Okay. Now let's look at the next disease process. This is the same individual. Now he's progressed. Now his MR is becoming more severe to the point that we call what's called moderate MR. And what you're seeing in this individual at pressures of intraventricular pressures around 50, the valve actually becomes incompetent. Okay? The next one is going to be the severe one, and this is one that most of the time is drawn in the test, which looks like this. This is severe MR. This is as soon as the valve is is trying to close, it doesn't close. So as immediately during the rest of the cardiac cycle, a very, very large percentage of the volume ejected is actually going backwards. So all this volume here is ejected back into the left atrium. Only this is effective stroke volume for this individual. Okay, that's what actually leaves the atrium, leaves the ventricle into the aorta. All right? Now notice one thing. In acute MR, the preload curve does not shift. There is no effective change in preload. The ventricle does not dilate in acute stages of MR. A lot of times it's hypertrophy, so it goes in the wrong way. But just know that in MR, you don't see any change in preload in the severe. So when you're looking at this, sometimes you'll get a picture in the test that will look stupidly like this. I hate when they do this on the test, but it's a personal pet peeve, but there's nothing I can do about it. They'll show you a picture like that, and they'll label it A. And they'll show you a picture over here, and they'll label that one B. And they'll say to you, well, which one's acute and which one's chronic? And you're going like, I don't know. There's no preload curve. What the hell is it going on? Okay? So, I don't think the questioner even knows what they're asking most of the time, but what they're doing is they're taking this curve and they're shifting it out for you like this. And I'll show you the next picture here in a minute. That's acute. Acute is the one that's normal, where it should be. Now look at chronic. Chronic, what happens is the ventricle becomes dilated with a chronic MR. Because the atriums get larger and larger and larger, and they empty more and more volume into the left ventricle, and the ventricle will eventually dilate. Okay? So when you see in that situation, the actual compliance curve will shift downwards because it's a dilated disease process. Okay? So this is a severe, but it's chronic MR. Okay? This individual now, when you look at the curve, it goes from this position, which is acute, and they go down to the side, more being chronic. But what they should have shown you, this is the way they actually did it on the test, which bothers me, is that this is a normal curve. See how the normal line's right on it? And this is the chronic one over here, which is down over here. It's just an alteration in the preload curve. That's all you're looking at. You're looking at a dilated heart now. That's why it's chronic. Does that make sense? Okay. Now, if you look at the actual ejection fraction for somebody who's chronic, it's still okay. Because even though a certain percentage of it is still lost, look how much stroke volume you still have. It's still pretty good. Okay, so normally as chronic conditions get really chronic, that's when they'll get worse and they'll slide out even more. Now, what will make the situation worse? What would somebody with MR like this get worse? Let's say I go from this afterload, then I bump it up to here. What's going to happen? And the answer is it's going to eject more and more out until it gets to this point before the valve opens. So people with acute, with chronic MR, if you drive their systolic pressure up and you increase their afterload, you'll put them in more profound failure. This is something we teach you over and over about congestive heart failure. Congestive heart failure, one of the things you want to avoid is increases in hypertension. Okay? It's simply from this model. Okay? If you increase it dramatically, you will effectively decrease your stroke volume and you'll lose it all retrograde into your pulmonary circulation, and these people will go into acute pulmonary edema. And this is why I do these things, because I know what happens clinically. It sort of makes sense to me more. Okay? Some people find it useful. I hope most of you will. If some people don't, just come back and talk to me again later on. Tell me how you're figuring out how to take care of people, and maybe we'll find a new way of doing it. So everybody's got a slightly different way of doing things. If you look at mitral regurg over time, this is a very classic example of what happens with mild. With mild MR, you see the V wave start showing up on your PA occlusion pressure. So instead of having your A, C, and V wave being almost all the same height, now you're starting to see an enlargement of your V wave. Okay? The degree that you regurgitate back will determine the height of the V wave. So when you go up on your V wave and you go up and you cause moderate MR, all of a sudden you get a very large MR. Now what also you don't necessarily see on this very well, but hopefully you'll see on your slide, is what does the PA waveform change look like? Let's go down here. In this case, the PA waveform, which is in green, does not show any signs of V wave activity at all. You don't see anything. The dichrotic notch is where it should be. Everything looks like it should be. But when you get somebody with acute MR that's severe, the moderate, what you'll see is that the V wave will now be right where the dichrotic notch should be. So it develops what I call the double hump sign. Okay? And this looks like to me a camel. You got the dromeria, here's Mr. Camel with his double hump. Okay? So if you see that, that's what they're talking about when they're talking about PA catheters. When they tell you, how do you find somebody to have acute ventricular ischemia of the left ventricle? And the reason is because the most common sign is acute MR. So you're going to get the double hump sign there. Okay? Now, watch what happens next. And I'm sure some of you have seen this, but you didn't realize what you were looking at. Sometimes you'll float a swan in somebody that's basically frothing. Okay? And when you put the PA catheter in, you'll notice the following waveform. The actual PA waveform looks like let's make it green. Has anybody seen that in clinical practice? You have one of the docs put in a PA catheter and they saw this. What do they say right away? Most people that are putting it in, they go, I've never seen a waveform like that. That doesn't make any sense. And what you're looking at is severe MR. Okay? The actual first portion of the hump, which is the actual systolic ejection from the right ventricle, is now competing against the left ventricle's ejection into the pulmonary circulation. So you can imagine, look what your PA pressures are doing. They're going skyrocketing upwards because they're mimicking what the left ventricle's pressures are doing. So these people now develop acute pulmonary edema. And they're the people that come in with acute frothy red sputum coming out of their lungs, and they're coughing up stuff, and they can barely deoxygenate. This is the patients you're going to see. Okay? This is kind of important in the sense you can pick up if somebody has a disease process. I actually did this one time when I was in clinical. The patient had deteriorated suddenly. We had a swan already ahead of time. The person had an MI. So I came in real quick, and they said, well, the PA waveforms look strange. As soon as I looked at it when I walked in the room, it says, the guy's got a blown out mitral valve. That's the only thing that'll do it. So we did an echo on the guy, and the actual papillary muscle was sticking inside the left atrium, floating, hooked up to the mitral valve. Okay? That patient goes back right where immediately? Immediately to the OR. You have less than an hour for that person to die. Okay? If you don't, the person's going to die very, very quickly because of acute pulmonary edema. It's going to be so bad that you're not going to be able to control it. Okay? So what you do is you afterload, reduce them as quickly as you can, and hopefully drive the pressure forward, not letting it go backwards. Okay? Yes? Right. Very large V wave. Yeah. It actually will look like a ventricular wave. You're going to be going like, it looks like like an actual ventricular wave, which is it's basically mimicking a ventricular wave. Yeah, but most people, unfortunately, if you get to clinical, and we'll actually look the whole thing, and they'll say what's in the middle, and they'll give you the reading, but that's not it. Where you actually, to actually determine where your volume state is at, is you have to look at the C wave. You have to be down here. Okay, so you got to pay attention to that. If you're taking your mean pressure, which is what a lot of people will do, then you'll think that the person's flooded, and then that's not necessarily the fact. It's just that the valve's becoming incompetent. It's failed. Okay? You may still have a person that's volume overloaded, but they also may be dry. and the valve is just perforated wide open. Okay. So treatments is maintained forward flow. So actually this is to decrease airflow is important. Okay. ACE inhibitors and direct arterial vasodilators are a good choice in this point. Nitroprusside may not be a bad idea. Maintain adequate preload, believe it or not, because most people think when they see this as too much preload, and it's actually not. The actual PA occlusion pressure is down here versus your means way up here. Maintain heart rate. Increases the heart rate actually will empty the heart more effectively, so don't want to slow these people down, so beta blockers are not a good choice. Maintaining an elevated heart rate is actually beneficial to these patients. And then you want to maintain contractility because decreasing contractility increases the effective volume and can cause more annular dilation and cause the MR to get worse. Let's go on to the next disease process, aortic insufficiency, also regurgitation, depending on where part of the country you're from. It means basically the aortic valve is becoming incompetent. It leads to an immediate volume overload situation. And there's so much volume that's returning from the aorta that it causes ventricular dilation very quickly. Acute aortic insufficiency will cause an immediate overload of the left ventricle. It'll increase very rapidly left ventricular end-diastolic volume, which increases your left atrial pressures because the valve becomes incompetent. So with acute AR, you almost universally see acute MR. It increases your PA pressure, and the patients usually result in a rapid pulmonary edema. A lot of times when these people present, you think that the person's got ischemia, and you're looking at, you think that you're dealing with a mitral valve incompetence, but when you actually listen to the heart, you'll hear a continuous murmur during systole, which is the mitral regurg murmur. But during diastole, the aortic insufficiency murmur will also be present. Okay? And that's usually a very, very bad sign. Usually that's an indicator to you that the person has an aortic dissection, usually involving the aortic valve. Aortic valves usually don't become incompetent unless you're dissecting the aorta with it. Okay? So that's something to be very concerned about at that time. So you need to do a rapid echo on that person as soon as you can. This is where you normally present. This is a typical sign. This is aortic dissection, a type 1 or type 2, okay? And it'll dissect downwards and involve the actual valve and make it incompetent, and it will lead to acute AI in several situations. If you're looking at chronic AI, on the other hand, it's more indolent. It's a more gradual event. As a consequence of the left ventricle will overload, but it basically dilates. So it begins to compensate very quickly by dilating. So you almost never see hypertrophy in this. You almost see immediately dilation. Unfortunately, the dilation is permanent. So with AI that's been on there for chronically, you're looking at permanent cardiomyopathy from dilation. It increases the myocardial workload because of the increases in pressure, and you have can have also a low aortic diastolic pressure, which increases the risk for ischemia because remember your diastolic pressure is maintained by the valve being competent, and then when the counterpulsation occurs from the wave and plus the normal compliance of the aorta compressing back down will cause the diastolic pressure to be maintained. But when you have an incompetent aortic valve, you have a very high pulse pressure difference. So with the aortic insufficiency, you get what's called a water hammer pulse, pop, very quick pressure. So you'll feel the pressure and then it goes away because the diastolic pressure is actually dropping on you very, very quickly in these individuals. So in acute aortic regurg, you get rapid PA pressure increases versus in chronic, you get a more gradual event, and people don't necessarily present, except for they present with large hearts. In acute aortic insufficiency, you don't see usually an enlarged heart. You see just rapid changes in pressure. What do you hear? You hear a diastolic decrescendo murmur. Okay, that's what you'd expect to hear. Okay, and this murmur is taking place during the normal aortic valvular closure point, which is after S2. Chest pain with angina has increased demands of the heart, allows less oxygen to reach. The person will get increasing fatigue, weakness. They'll get increasing dyspnea, okay, because of the amount of decreased pulmonary compliance and increased water content in the lungs. There are two main reasons for the shortness of breath. Mostly it's orthopnea or paroxysmal nocturnal dyspnea can occur. You can also, if you get too long, where you don't have enough forward cardiac output, you get syncope, which is a very bad sign, which is an indication of reduced cardiac output. Usually when you see that, you also start to get renal insufficiency, and you'll see your BUN and creatinine begin to rise very rapidly in these individuals. So what do you do? What do you see in acute AI? Acute AI is a disease of the valve not closing properly. So that point is actually here. Okay? So in aortic insufficiency, the volume returns back into the atrium, into the ventricle. Instead of the ventricle staying isovolumetric during the relaxation phase, the volume immediately returns from the aorta back into the ventricle. And what you'll see is that instead of having an isovolumetric line going straight down, you'll have it actually shifting this way. So what does that do? That means that here, from this point here, that's your effective stroke volume. All this volume here is ineffective. Okay? So it's like mitral regurg, you go in the reverse on the opposite side. Okay? And that's how you pick it up. In mitral regurg, the isovolumetric line changes on the mitral valve point this way, versus in aortic insufficiency, it shifts down this way from the aortic valve point. So the way I remember it is, just think about the valves, where the hinges are at. Imagine there's a hinge here, and there's a hinge here. Okay? If this hinge is flipping this way, that's aortic insufficiency. If this hinge is flipping this way, it's mitral regurgitation. Okay? That's the way of looking at it. Now, acute AI will not really change your compliance curve. So your compliance curve is still the same. Okay? But what happens with severe acute AI is that your curve shifts more and more and more. Okay? Because the valve becomes more and more incompetent. So you can see this angle becomes more severe. Okay? That means here is ineffective stroke volume, and this is actually effective stroke volume. So this person is losing out on their effective stroke volume. Now, the question you have to ask is, why is afterload decreased in these individuals? Because that's how I've drawn it, right? If you look at this picture, you can see the afterload number is actually dropped. And the answer is because the valve tends to open more rapidly when it's incompetent. Okay? So literally, the afterload has dropped significantly, but the afterload that peripherally has not. So that's why the pressure keeps rising until the end. Okay? Because the afterload that you're pumping against is still sort of present peripherally. Just the valve itself is not what's keeping the valve from opening anymore. It's actually opening much more rapidly. Now, with acute AI, it usually presents with severe MR because of the dilation of the heart and when they overload in volume, and then you get pushing the pressures back, and these people will develop edema, so they'll cough, shortness of breath. And you'll see also enlarged V wave as well in these individuals. And so that's what you got also with severe MR. Now look at chronic. Here's where the trick is again. Okay? Acute AI is kind of weirdly drawn on this picture. Okay? This is very mild, by the way, because what they did was they opened up the valve down here. Okay? So this would be a mild acute AI, versus a real wide open AI would look like this. Okay? You can see the chronic AI, what has happened to the preload curve. The preload curve has gone from here, now it's shifted down to here. Because it indicates what to the ventricle? The ventricle now is dilated. In chronic AI, the ventricle is dilated. So you see the preload curve has gone from the green line up here and it's shifted downwards. And that's what gives it that appearance that it's further out. It's because the compliance changes in the ventricle is dilated. Okay? Same kind of drawing, except just chronic AI is just slightly difference in the preload curve point.
So does that have less pressure?
Yep. Yep. So that means that you have a lot more volume inside the heart with less pressure. So a lot of people, when they look at the patients with severe AI, with chronic, their PA occlusion pressure will actually appear low. And you go like, why is it like 8? And the person's in edema, at congestive heart failure. And the reason being is that their heart's so full. A lot of times you'll also present with MR with this as well. So usually with chronic AI, you're replacing 2 valves. You're replacing the aortic valve and the mitral valve. The reason you're having to replace the mitral valve is that the annulus gets dilated. And now the valve is no longer the right size anymore. Yeah. and you can't replace the annulus, so you got to take out the valve and replace it with a new, bigger valve. Okay? So this is a failing chronic AI. This is a patient that goes from a contractility state that begins to diminish from ischemia, and what you'll see as a consequence, you get an effective stroke volume will greatly diminish in this situation. So you go from, let's go from previous pictures, hold on. This is your effective stroke volume in this individual. This is okay. And then when you fail, the heart begins to fail, this goes into congestive heart failure, then now the effective stroke volume has diminished significantly. Okay? Just from the drop in effective stroke volume. Okay? All right, AI pressures over time. What you see is you get a rapid, a very big diastolic pressure descent. Okay? So if you look at this radial A line, what do you see is missing? There's no dicrotic notch. Dicrotic notch is gone. Okay? So you want to pick it up. Okay? The other thing you'll see is a lot of times you'll get a prominent increase in your X descent, which is what this is right here. I'm showing that very well. I'm not going to ask you that, so let's leave it alone. Just the X descent becomes more prominent. That's a little bit more than what you need to learn right now. You got enough to learn on it as it is. Okay? Now, how do you maintain or how do you manage somebody with the AI? And the answer is you have to maintain them with adequate preload. If you decrease the afterload, that's actually a pretty smart move because you basically can effectively increase the effective stroke volume. The only downside to that is that you can drop the diastolic pressure significantly and cause a problem. So you're kind of between a tightrope. AI is really a nightmare. You've got to sort of keep them right and sort of between two tight numbers. One, you don't want to drop the diastolic pressure too low, but the afterload is also pretty important to maintain down. Increasing heart rate is okay to do, but not too much. If you get them too rapid, then you'll drop the preload, and then what happens is if you drop the preload? If you drop the preload and you're down here, what's going to happen? You're not going to have anything. And that's your effective stroke volume. Okay? So you got to sort of be careful. AI is bad news. If you have to take care of it, we'll talk about it more in coexisting. So these people, you want to maintain adequate filling without really causing too much of else. You want to keep them where they're at. This is what I was trying to show you here. This is what happens when you decrease the afterload. This is the proper management. If you decrease afterload, you'll get a much more effective stroke volume in this individual. And as you can see, the stroke volume went from this to this. Okay? Just by decreasing afterload. Okay? All right, that's what I was trying to show you here. This is the actual stroke volume difference. Okay. Now, last one we'll talk about, and this will weigh in for the day, will be mitral stenosis. Okay? Most mitral stenosis takes about 20 years to present. It's usually found in women because women have a much higher predilection to developing rheumatic fever, which we don't know why. So about 70% of females that develop rheumatic fever will get mitral stenosis over time. It's a progressive disease, and it takes about, like I said, 20 or 30 years to develop. Your valve orifice goes from a normal 4 to 6 centimeters squared to less than 2 centimeters squared. Okay? And usually we see when you're under 50% of the actual valve area where the patient becomes symptomatic. And what you're seeing is that the person develops chronic dyspnea. Literally, the left atrium will become very large. It'll be so large it begins to compress on the left recurrent laryngeal nerve. So some people will get hoarse. Okay? As the atrium dilates, it will also start getting into atrial arrhythmias more frequently, which can be lethal in these individuals. But as the PA pressures begin to rise, this person may develop persistent pulmonary hypertension, even if you fix the mitral valve. So you get decreased lung compliance, increased lung water content. Atrial fibrillation is common, but it's usually very symptomatic at that point, and the compression of the left recurrent laryngeal nerve due to the dilated left atrium. You also will get a diastolic murmur with this. Okay, it's usually a mitral snap followed by a rumbling murmur. Again, this is a diastolic murmur, so any diastolic murmur is usually not a good thing. The other thing that it has an increased risk is because of the enlarged atrium is that there's an increased risk of developing thrombus in the atrium. So these people can also throw PEs, not so much PEs, but throw out emboli, thromboemboli to their brain or to their periphery. What you see with mitral stenosis is you get a very prominent A wave, and because the mitral valve is contracting against the very fixed, so this is a normal individual, okay? But in a bad situation, you'll get, in mitral stenosis, this is what you see inside the left ventricle. So when you look at the left ventricle, what happens? There's not enough volume getting in there. So preload is very, very low, even though the person is wet when you hear them. Their left ventricle is starving for volume, okay? So what you see if you look at the pressure volume curve is a significant reduction in preload. Their afterload stays fixed or slightly elevated in most individuals to maintain perfusion, and that's what you see in these individuals. So a nice little narrow space. Okay? What you also will see is that the ventricle really doesn't dilate or change, so the compliance curve doesn't really shift in this disease process. Now what you do see on your ventricular compliance curve is that your pressure over time curve, when you look at the A wave gets very large, okay, so you get a very large A wave. And what this does when you're looking at your PA waveform is you'll get this kind of weird waveform that looks like this. I call it the Boy Scout sign. So you got like 3 fingers up in the air. That's what the PA catheter looks like. Okay? The first curve is the actual the atrial kick. It becomes so large. Now, what happens to that A wave when you go in atrial fib or atrial flutter? It disappears. So you won't see that. So if you see somebody's atrial fib and you put it in a swan, you won't really pick up that the PA pressures, except that it'll be elevated, but you won't see that other A wave. But if you have a normal sinus rhythm and you're squeezing against a tight stenotic mitral valve, then you'll get a very prominent A wave. Okay? And the dicrotic notch, and the PA waveform will change as a consequence. Okay? Does that make sense? Mitral stenosis leads to a decrease in left atrial emptying, increase in left atrial preload. Okay? This leads to pulmonary edema, which increases your PVR, pulmonary vascular resistance, decreases your oxygen supply. It leads to eventually right ventricular failure, what we call cor pulmonale, eventually left ventricular failure from lack of oxygen delivery to the left ventricle. The other thing that you get is a decrease in force in left atrial contraction, which decreases your delivery to the blood to the left ventricle, which leads to a low left ventricular output state. Okay, literally the left ventricle is starving for volume. So with mitral stenosis, do you keep these people dry? You do that, you'll kill them. Okay, so you got to make sure that you get the right diagnosis. These people, if you come in and they have severe MS, the best treatment is surgery. That's the best treatment. The best treatment is not to muck around trying to keep this person dry or something like that. If you dry them out, your left ventricle will not have any volume, and then you'll develop renal failure, and then they circle the drain for the rest of the time. Okay? The best thing to do is get them back into the operating room, get them fixed. So don't wait too long, put it that way. The LV cannot pump without adequate preload, loss of stroke volume due to loss of volume, increased left atrial size, large A wave leads to an increase in PA pressures, pulmonary hypertension. Chronic will lead to RV failure eventually, elevated RV pressures, and tricuspid dilation, in which basically you end up having a right-sided heart failure. So you're going to get liver failure, coagulopathy, ascites, the whole works. Okay? The only thing you want to avoid. And here's so I'm going to sort of give you a hint. This is where you should talk to your buddies about this when you're doing your cardiac workbook. When you look at right ventricular valve diseases, basically you're looking at the valves are before the heart, before the lungs. So you're looking at lungs that are essentially dry most of the time. So they're isolated. Even if it's stenotic or regurgitant, whatever, usually the lungs are dry. Okay? Usually the left ventricle has insufficient volumes, so you usually see associated decreases in PA occlusion pressure as well as decreases in PA pressures in a lot of the time. The effects are seen more in the RV waveforms, which is you actually put in a swan, you actually measure an RV waveform, and you also reflect it back in CVP. So CVP, if you look in a tricuspid regurgitation, you're not going to see it in a PA occlusion pressure. You're going to see it only in CVP. Okay? So that's what I sort of want you to do. I want you to sort of review the waveforms for the cardiac workbook. So if I decide to pick out a question about, say, tricuspid regurg or tricuspid stenosis, what should you expect to see Would you expect to see a PA occlusion pressure measurement difference? The answer is no. Should you expect to see it in the CVP? The answer is yes. Which one are you going to see? Large V wave for CVP and TR, large A wave for tricuspid stenosis in the CVP. Okay? So I want you to know the difference between CVP and a PA occlusion pressure. Okay? And that's what I want you to sort of concentrate on. That's your homework for the week. The disease process themselves are very similar in the sense it's the same kind of etiology, rheumatic fever. Most of the time, right-sided valve failure is not as bad as left-sided. Left-sided will kill you fast versus right will take a long time. Okay? And actually, there's one of the treatments of choice is if you have severe pulmonic stenosis, you know what we do? Remove the valve, and that's it. We leave the valve incompetent. Patients do fine. And they're not going to run, they're not going to exercise like marathoners, but they'll still have a normal, productive life. Okay? So, okay.